the panelists today. Our first panelist is Dr. Farizi. I might butcher your name, and I'm sorry.
You're fine, Lisa.
Has an academic researcher as well as research administrator for over the past 20 years and has collaborated with multidisciplinary teams in all phases of her work. As an administrator, she has built and continues to build productive teams, efficient processes, and sound infrastructure for both academic and industry-sponsored research programs. Scientifically, she has expertise in both quantitative and qualitative research methodology and has been involved in projects and have resulted in numerous publications as well as quality initiatives. As a medical sociologist, her own research has focused on quality of life, health outcomes, and risk factor assessment in both cardiovascular and liver disease. Our next panelist is Anne Schnatter. Anne has been involved in clinical research for 22 years while pursuing her nursing degree at Case Western Reserve University. She was introduced to the world of research as a data coordinator. Anne began her career in cancer research at University Hospitals of Cleveland Seidman Cancer Center in 2000, concentrating in lung cancer and HIV malignancies, including the opportunity to work with international sites in Africa. Anne jumped at the opportunity to move back to the mountains and family in Western Maryland in 2014. She has greatly enjoyed working with the various research professionals on campus and bringing clinical research opportunities to our patients and clinicians across the state. The next panelist is Shelley Welch. She is co-director for the Clinical Trials Center of Excellence, where she has oversight for the operational team to execute clinical trials. She has over 18 years of experience in research industry, 7 years with WVU and 11 years with a local contract research organization leading clinical research teams. Our facilitator today is Debbie Lee. Debbie has been with WVCTSI, the Center of Excellence, for 2 years, and previously she had worked at a contract research organization for 17 years. She has experience in being a regulatory associate and leading teams. So I'm going to pass it over to you, Debbie.
Okay, awesome. Thank you so much, Carrie. So we're going to start with our panelists, and I'd like to ask a question about how would you like to know, we would like to know a little bit more about your career pathways. So please tell us how you got where you are now, and did you think you would be somewhere else? So I'm actually going to start with Anne, if she doesn't mind answering.
Thank you, Debbie, and thanks everyone for joining us today. So did I think I was going to be where I am now? No, not at all. Honestly, when nursing school, I really thought that I was probably going to be in the Peace Corps in the middle of South Africa, somewhere in Africa, for the last 15 years. So that's really where I thought my passion was lying. But, you know, having the exposure as a nursing student into data coordination really opened up my eyes into another world of nursing and healthcare involving clinical research that I hadn't seen before. So I was lucky to be driven down this other path now.
Awesome. Well, we're glad you're here. So, Lisa.
No, I also did not think that I would be where I am or doing what I'm doing. I started down an academic pathway. I was a late bloomer. I graduated undergrad, did some odd jobs after that, and then decided to go back to graduate school and did my master's and then my PhD, and was very focused on the academic model of thinking I was going to grow up and be a professor and teach and have this, you know, have my dog in the classroom and, you know, have this lovely kind of crunchy academic sociology job. And I just got thrown into research as graduate students do and really liked it. And then life event happened. I got divorced and was talking with a physician in Northern Virginia about being on my dissertation committee. and he asked me if I wanted a job. And so there went my pathway, just completely went a different way. And I ended up taking more of an administrative operational job to start to work on building a research department for him. And then it just has continued since then. So happy to be at West Virginia. I moved from Northern Virginia about 4 years ago. Much better life here, much better work-life balance. The commute is much better here. There's no traffic in comparison to Northern Virginia. So
I'll have to remember that next time when I'm getting road rage in Morgantown traffic.
yes, just think of me. I used to spend 3 hours in the car a day just to go like 15 miles.
that would not be good for me. And I like that you also had a life path for your dog, that you wanted him to be.
I was going to be that professor that had the dog in the classroom. I can't find a way to get the dog in the hospital. I think I'd have to certify them as a therapy dog or something. So I haven't figured that out yet.
Could be another Gus too.
Oh yes, yeah.
I can try.
Great. Shelley.
Yeah, thanks everybody for being here. I was probably late to clinical research in my nursing career. I graduated nursing school in 1981 and had a couple of careers before research, and mostly, some acute care, and then like almost 15 years in home health, and was looking for a change. And I don't see Louise, but I saw her jump on. But Louise Moore was working in cardiology at the time here at WVU, and was getting ready to leave there, and said, hey, you should check out this job that I'm getting ready to leave, and I think you'd like it. So that's how I got into clinical research. And just looking for something different, and tag on if research isn't different than what you normally, hear and see and learn about for nursing anyway. And so, took the job in cardiology as a research coordinator and absolutely loved it. Was moonlighting at the CRO that I moved to. And then they lured me over full time at the CRO, and I learned a lot from the CRO industry to how to manage clinical sites like we are. And then again, was just looking for a change, and happened to, apply at WVU, and ended up, back. And I think it's back at WVU. So my 7-8 years have been broken up in between, like 10 years at a CRO. I think the joy of the position that I have now is you have a little bit more interaction with the patients than I did with the CRO, because we didn't see any patients. You talked to them on the phone, but so I think being a little closer to the patients, and the passion for research. I don't, as I end up my career, I don't think that I'll shift gears again. I hope to, in my career in research. It's definitely, like I said, something that I never thought about when I was in nursing school. Was basically introduced to it, but back in the 80s, there wasn't much research in nursing going on. And so it was one of those career paths that I didn't know existed, but certainly glad that I found it. And so definitely did not think, that I would be here. If I think about nursing school, I thought I would be in acute care and go up the ladder in acute care. Well, that's acute care, as many know, it gets old very quickly, especially when you have family working every other weekend. It's a hard road, to stay on, and a hard path. So I was definitely looking for something other than acute care when I left acute care. And for me, that was home health for some time, but then, looking for a change. Sorry, I didn't mean to take so long.
Well, I was timing you now. I'm totally messing. And I'm glad to have both Shelley and Lisa here. I don't want you to think I was favoritizing Anne when I said we were glad to have all of you at WVU. So for those of you that are on the phone, if you have questions for our panelists, feel free. You have been muted, but you're welcome to take yourself off mute, ask questions directly, or if you feel more comfortable putting something in the chat, either to everyone or to me privately, that's totally fine. I will not divulge your name if it's private. So feel free to do that. So while you're maybe thinking of a question, I'm going to go ahead with a question that we have here. What are 3 things you couldn't live without on a daily basis? And this time I'm going to actually start with Lisa.
Oh,
Oh, sorry.
only 3?
Only 3.
Okay. Water. I'm like a waterholic. I know it's crazy, but if I don't drink water, I don't become a very nice person. Laughter. I have to laugh like during the day, because if you don't laugh, you're going to cry, right?
Mhm.
Or scream or something like that. And then I'm going to say sweets, because I
Mm.
like chocolate. And, pretty much any other sweet you could put on my desk, I will eat. So I would say those 3 things.
Okay, awesome. I could definitely get behind the chocolate, just saying.
I always have chocolate if you need some.
Okay. Anne.
3 things according to my husband, if you would ask him, I couldn't live without, or me. Because they're probably different.
This is your
And
presentation.
hopefully no
We'll
one
go with-
talks to him about what I will say. I will say my dogs. I think definitely, the dogs, and just that, 100% dedication that animals provide to us, and loyalty factor of any pet that you may have is always welcome. Laughter. I think I do agree. I think no matter what happens in our world of clinical research, it can be very stressful in our personal environment. And we all know that from this past year. Laughter is something that has to happen on a daily basis, or you will go insane. Third thing, professionally, I will always say a team. I'm not a solo only person, solo employee. I really thrive on collaboration. So I like input from others. I don't want to be the one that's sort of solely leading everything. And so I do like to have lots of people around me, even though I enjoy my quiet time as well.
And Shelley.
Yeah, that would be my first answer, is my team. And that is really broad. People, as Anne mentioned, to surround your people that have shared passion with you for what you're doing, because I spend a lot of time at work. We all spend a lot of time at work. And so being able to love what you do is important to me. And I've been fortunate to be in places that I love doing what I do. And so that big collaborative team, not only, within COE, Tanya's team and the CTSI, but broader at the university as well. I think it's a very welcoming, very collaborative environment. So that's super important to me. And then probably more personal would be exercise. I have to exercise, whatever form keeps me busy and keeps me active. Exercise as much as I can. And then, family, dogs included, family and friends that make the day go by quickly.
Thank you. Lisa, do you want to revise one of yours to your animals?
My cat.
Your cat.
Don't tell my husband, because of course he thinks I love the cat more than him. Which,
Oh, okay. Man, we're keeping lots of secrets on this
Right.
session.
And of course, I would have to, my team as well, having collaboration and all that, I second everything that Anne and Shelley had said, but we'll add the cat in there.
Yeah, absolutely. Gotta add the cat. So for those that work with a lot of different departments, I think that's something we do a lot here at West Virginia. How do you help to streamline processes, procedures across those departments? And I was going to start with Shelley first, but okay.
Yeah, the fire alarm has not gone off. So if I go off on mute really quick, you'll know why. Yeah, that's for the people that we work at with CTSI, we work with a lot of younger research members, right? That's our role, is, young investigators. And so I think building trust and building a good communication is important, so that they know we're here as a resource and can ask questions. And if we don't know the answer, we have a broader team within CTSI to help get the answer, or even without, above CTSI, the various units in the institution can help provide answers. And then I think the other thing that would help would be to have, written procedures, SOPs and work instructions, for those real concrete processes. Some of the processes may not be, lend itself to being in writing, but, more of a one-off. But I think where you can, it's important to have, written consistent processes, so that, things are, done uniformly when possible.
Awesome, thank you. And as most people on here know, I love my checklist, so I'm all about that uniformity. Lisa.
I would agree with Shelley. I think it's determining or establishing the communication, and then kind of trying to keep everyone on the same page with some consistency. I think that's when it gets confusing. Research has a lot of moving parts. There's people, even within teams, even with our own team, tend to do things differently. And so when you start thinking about having to bring multiple areas together or to execute something, it's trying to simplify it, trying to hold everybody to the same basic standards, so that we're good stewards of research, no matter who, we have contact with, that we have some uniformity to that. And then just continue to have open communication and revise. I think process improvement, one of the keys to that also is the revision. So if something's not working, change it, come up with a new idea, and have buy-in. So if you're working with a lot of different areas, like we've done a lot of work with procurement and contracting and all that stuff with devices. And I think what was important for us was to just bring a lot of people to that table early on and let them have a buy-in to how that process is going to go, because we certainly didn't know the best way in their area. And so I think having them buy into that and have a say in how that goes can be very helpful.
Perfect. Thanks, Lisa. Anne, is there anything you want to add?
Yeah, so I'll build on to, what Lisa said, is that you have to be flexible. In developing processes and standard workflows, it is difficult when you're kind of going across the gamut of various departments across campus. I know we've been working on that with the COE right now. Some things have to be standardized, and in general, but how you have to offer the flexibility for each department to identify their team members that will be acting out some of those procedures. I think every department here is structured in its own department. Every protocol we read is, you'll read one protocol, you just read one protocol, you can't really cross over what one protocol states to another project. They're all unique projects. They're all unique objectives. And I think just sort of identifying what your endpoint is and kind of working backwards to those objectives is key. I think for us, the biggest thing that you'll see from a successful team and a successful department is when the PI considers himself an equal to his research team. Everyone has to have the ability to speak up when they feel that something either isn't either correct for the patient or isn't the best for the science of the project, and just kind of, keep everyone 100% accountable, but everyone is completely transparent into meeting the objectives of the department.
Awesome. Thank you guys so much. We do have a question, so I'm actually going to pass it to Tara Riddle. And Tara, you are currently muted. There you go. Okay, great.
Yeah, well, my dog, I've got 2 new puppies in the background, so hopefully they'll be quiet, but they're playing right now. So I was wondering, I think how to frame my question. What do you consider the most frustrating part of your job? Like what do you feel is like the one thing that you could change and make it better for your teams?
Hmm.
And then on a side note, Shelley, do you think you could explain to everybody what happens when your pinata gets stuck at the airport?
I can. Sorry, the alarm at the hotel is going off. Actually, it may have just stopped.
So we can't hear it on our side.
Yeah, I think it just stopped.
Okay.
I'll take the first question. Can I go ahead, Debbie?
Yeah, that's fine. Go ahead. Sorry.
Tara Riddle. That's funny. And so I think the one thing I would change, or one of the challenges, I think one of the struggles that we have, and what frustrates me, is probably the lack of enrollment in the clinical trials. If I look specifically at our trials, I think that most of our trials we struggle to enroll, and so I think it's to be good stewards of the funds and the resources. It benefits everybody to enroll, and I think that WVU can be a little bit more well-known in the community, where we're not right now as a research institute. I think that there's benefits. The benefits outweigh the risk for the clinical trials. And I wish that more people in West Virginia knew that we have resources here at the university for clinical trials. And my goal, my long-term goal, if I end my research career and there's, at WVU, which I intend to do, but, some type of patient registry portal, that if you're interested in clinical trials, you could, as a patient, register for those clinical trials and then see what's available, and make it easier to enroll into a clinical trial at WVU. That would be my most challenging part of my job, is getting patients enrolled. Because quite honestly, bringing a study up and doing the regulatory, while it's labor intensive, it's very structured. It's, you can do that. All of us can do that. What's challenging is finding the right patient and them willing to be enrolled in the trial. So that's the one thing I would change. And for anybody who wants to hear the pinata story, I'm happy to, go offline with the pinata story. It's a fun one.
I think there was also photos, just saying.
Yeah, there might be.
Lisa or Ann, do you want to either add to that or provide your own maybe frustration?
No, I'd want to jump on and piggyback to Shelley. I mean, I think the most frustrating part isn't just, a lack of patient enrollment. It's our own clinical partners who forget sometimes that, we can only have these new treatment options for them to offer patients because other patients, people like us, participate or led these clinical trials that these patients had volunteered and participated in the past. So the only way that we can move forward is by partnering with them. And I think sometimes it becomes frustrating when the clinicians think that we are invading into their patient care paradigm more than trying to collaborate. And I think I would love to dispel that, myth, not just to our patients about the fear of clinical trial, but the myth to our fellow clinicians, that this is not anything that is taking away from their contact or their patient care, but hopefully adding to the science of the career that they chose.
And I would actually, I'll further that whole trail, because I agree. I think, maybe Shelley, when we retire, we can you know, maybe we, in our retirement, we can go do, you know, education across West Virginia to the
Yeah.
communities, you know, because I've long thought similarly is that kind of the fear of participation in research is definitely, having come from an area in Northern Virginia and moving to West Virginia, there is a difference in, you know, patients' trust of research and that whole, what it means to be in research. And so there is that piece. And then to add on to Anne's, which is the collaboration with the clinicians that are not necessarily the ones spearheading the research. And so for me, I feel like I have a degree in research education because I feel that, you know, from both of those components, both from patients and family members and clinicians and bedside nurses and procurement and, you know, even environmental, you know, like every department that kind of exists in this institute, I feel that I have to continuously explain research, which is fine. But you know, sometimes in a day when you're doing it 10 times and you're like exhausted and you're just like, why can't everyone just understand this? You know, this is like, and so I think I often, or, you know, for me, I often feel there's, you know, like it's an impediment to moving forward, but then, you know, you drink a glass of water or coffee and you calm down a bit and then you're like, okay, I can do this. And then you start your education over again. And I think the clinicians, if they haven't done research, they don't really understand the significance of it. And then on the flip side of that is all the work that goes with that if we are enrolling their patient, like we have to have these things and they're not just something that we're trying to be difficult about. It's like for the study, we have to do these things and they're not optional and you can't do it the way you want to do it. We have to do it the way the protocol says we do it. And so I, you know, continually, you know, trying to get, when you do get a patient enrolled and then you're trying to make everything happen, all of the hoops that you know, that you have to jump through. So I would say just that frustration of really the understanding of research across and research, because I think people also look at WVU and they know it's a land grant institution, there's research, but what the professors do on the academic side in their labs is very different than what we do. And so we are, those of us here on this, you know, seminar, we are the ones that are making clinical trials happen. And so, you know, it is a very different, when you say research in our world, it's different than if you say research in Dr. So-and-so's lab over at the university. And so trying to still, you know, educate and get that information out. So.
Hey,
Absolutely.
Debbie, I saw Jackie's comment about Pitt plus me. I hope I've been aware of Pitt plus me. I've looked at it and that's pretty much exactly what we want to do. It's just finding the resources and being able to, you know, to implement that. But that is the vision that I have as far as a registry. So thanks, Jackie, for the comment.
Awesome, thanks. All right, so my next question for you all is, how would you go about researcher-initiated low-budget clinical trials?
Can I start that one too?
Yeah, go ahead. Yep.
So I think that investigator-initiated studies, you know, have challenges. One of those, you know, may be budgeting and not having the budget within the department. I think that there are a couple things that come to mind for me, you know, especially where I'm situated within CTSI. I think you can always look if that, you know, if that protocol would fit within CTSI grant funding mechanisms or scholar mechanisms, because there are a lot of mechanisms within CTSI, as though, you know, many know that, you know, there's small grants and then there's pilot grants and then our scholar activities. Those would be what I would recommend upfront first, because then it would be, you know, local. I think there also, you could look at perhaps grants outside of, the university. There are many other types of grants, NIH grants, if it's a very, very large project, and we have resources to help with that. And then I think also that, depending on where, what the therapeutic area is, there are other, maybe pharma companies, maybe other types of, institutions within that therapeutic area that may offer grants. So I think you could look, to those resources as well. And then, if nothing else, I think that the investigator could, plead the case to the department as well. And if it's, something that they can, perhaps fund, it really just kind of depends on the type of the protocol and what funding really is required.
I would add on to that last piece, well, everything that Shelley said, but I think when we have investigator initiated studies that we can't find these other mechanisms like pharma or a grant, family foundation grants sometimes will fund, investigator initiated stuff. But I think I always, finance people don't like it. So if you're a finance person, my frame of thought is I always try to frame things like what will it benefit back to the institution and the patient? So it brings something to the patient, but then does it also set that investigator up for, a set of publications or, presentations on a national podium that puts WVU's name out there. And although it doesn't equal money, but sometimes, depending on the significance of the project and going to your department chair or your department to ask for funding, you can, sometimes plead that it's going to bring a recognition. Maybe it's something unique that, only WVU is doing in this whole region or state or something. And so although we might not have $20,000 to do it, in the long run, it could, bring patients into our service line. So just thinking of out of the box ways to sell your project, and, figuring out if there are any kind of funds that you can cobble together or just do it and take a loss. There's always that.
Yeah, I mean, I think, and just to add, like, I agree with everyone's points. You can exhaust internal resources, but I think sometimes what researchers, when they're writing their own studies, one of the mistakes they make is being too broad in what they're looking at. And so if you know that it's not going to be funded well, really having direct objectives that you'll be able to fulfill and not fill it up with a lot of what ifs and different tangents.
Sure.
Because then if you're spinning too many people involved in the project, it just does become too overwhelming to get to the details of it. So keeping it simple, I think if you're starting off and you don't have that funding, keep it simple, prove your primary objectives, and then you can build on that and reapply for funding based on that initial project success.
That's good advice, Ian. So narrow the focus down to what your objective is.
Yeah. Yep.
And I think that is for early investigators, that is one of the things we all see, right? They try to bite off way more that, and I know, Shelley, from your end, like the grants that come through CTSI, because I know just from our end, when you first look at them, you're like, these could be 5-year projects,
Right.
How many aims they have. So that's an excellent point, Anne, to be specific and succeed at one thing and then build on that.
Yeah.
Mhm.
Sorry, just checking the chat to make sure. My next question I'd like to ask is, what are some overall pitfalls you have encountered?
Right. Over the past year.
The past day, the past week.
Take it out of it. However, whatever time frame you would like to use.
Pitfall seems to be a very large word, so I don't know. I guess it's hard for me to say pitfalls. I mean, I think we're talking about frustrations when Tara was talking about enrollment. I mean, I think honestly, even if I talk about this past year overall, how we've overcome some of our pitfalls that I think we had at this university, with centralizing systems and centralizing processes. I think one of the largest pitfalls I've had, and in the beginning in the bio that Carrie provided, I did come from a very large academic institution that had, lots of centralized resources and people that can assist you, but you still could feel like if you were in a department, you were all by yourself. So I think the largest pitfall that we have here at WVU that we're trying to overcome right now is that silo mentality of every research department. I think it's knowing that you can be transparent and work with and collaborate with other departments and find out what they're doing and to ask those questions before you're trying to suffer along with a project or going to a point where you're going to have deviations or possibly the failure of a trial overall.
I think that's a good point. And because I too came from an institution that had and plus having been at an institution a long time, I think for me, coming to WVU, I still say I'm new, even though it's been 4 years. But when you leave somewhere where you have a centralized infrastructure and you've been there a long time, and you can walk in the door and you kind of know who to go to, and you've got your people and your processes, and that's, and then I think, we have, with the COE, creation, and then the tech, the work that we're all doing together, I think it is starting to open up that conversation across all of us that, hey, we are not alone, even though we are all in our different areas and we're, and we're all structured very differently across the system. But we do have each other as resources, and we should be utilizing that more. And that in and of itself will start to create that those processes that then everyone will start to implement, and you'll see more standardization and you'll see more cross pollination across all of the areas.
Mhm.
But it's hard too when you get in your day and you're just kind of focused in your stuff, and then you sometimes forget there's that world out there. Oh yeah, I can reach out to Shelley, reach out to Ann, Tanya. I mean, name any of the names on this screen that we all have access to.
Yeah.
And everybody brings something different to the table.
Mhm. Mhm. One of the things I would call a pitfall too, and this is probably a little bit more granular, and I agree with Lisa and Ann, but I think sometimes people overlook feasibility, especially with industry trials. A lot of times, the team is really excited about getting the protocol and really, excited about the intervention that it could bring and doing the project. I think one of the things that is really important is, and it gets brushed over in the whole process, is really feasibility. Do we really have the patients that meet the criteria? Because especially with industry, there are so many inclusion exclusion criteria that, once you get that full protocol, really take a deep dive into the feasibility of conducting the trial at WVU. One of the tools that will help that we have is Trinetics. And so if you're not familiar with Trinetics, please seek me out after this. It's a very good tool to be able to, to look and see whether you have the right patient population based on that protocol. And then, even if you see that you have the patient population, I think that, overestimating the number of patients that we can enroll is a tendency that researchers, think that just because they qualify on paper, well, they're going to want to do it. Well, I find just probably the opposite. Probably you could, if we have 10 patients that qualify, I'd probably cut it in half, that those would want to enroll because of the location of what we do. We're a tertiary referral center, and as many of you all know, that the patients can drive hours over, crazy terrain, and depending on the amount of, follow-up visits and the the structure of the protocol, it can be very time consuming for patients, and they just may not have the ability and the resources to be able to do that. So for me, one of the challenges is really surrounding enrollment of the patient. And I think it starts really with feasibility and doing a really accurate and taking accurate feasibility questionnaire and making sure that we do really have the resources to do the protocol.
And I just want to build back on what Shelley just said. Sometimes feasibility isn't just for we have the resources to do the study. Sometimes it's proving to our industry partners that it is feasible to bring this research to us.
Mm-hmm.
And I think that's one of the, I know over my last 7 years here, and really I came back here to do the statewide research network and the oncology, across oncology practices in the state. And we had to have many conversations with industry partners that we have the patience. We definitely have the patience, but there's certain things that we need to have in place, whether it be more patient reimbursement, transportation issues, connectivity issues, providing patients with outside resources, providing patients or allowing them to get labs at different facilities because of our terrain and because of our, financial status for many of our patients. They might not be able to come here, but it doesn't mean that they don't want to participate. So yes, I think, it's a pitfall also of us looking at our feasibility, but also industry looking at how feasible it is for us to work with them.
That's true. That's a good point. That's a very good point. We may be writing a grant for this is news for a mobile clinical trials unit to go out into the community and bring clinical trials to rural communities.
Yeah, and we have that, like, between Bonnie's bus for the mammogram and now the new lung cancer screening bus that's going out in June. Both of them have clinical trials that they collaborate with us, the Cancer Institute, that they offer to the patients on those screening buses too. Yep. So we find a way to get to them too.
Okay. Next question is, recently Clinical Trials Toolkit did a presentation. It was actually Anne and Tanya on Encore and eReg. How are your departments currently working to enter in clinical trials into Encore, or just using Encore in general?
I'll start since I'm like the newbie in this.
Okay.
So I'm looking at, the experience between Shelley and Anne with Encore is, certainly is more than we have. And I'll be honest, it's a struggle, as a department that didn't exist 4 years ago. So we've not only had to build a department and all of the processes and work that goes into just that, and then trying to take on something that we don't have experience with as a group, and so the people that have Encore and eReg experience have gotten it here through this initiative, and so we don't have a lot of background to go with, so it's hard. We're muddling our way through, and we're getting stuff entered, and then we have had some staff departures. So everyone knows what that means, is then you figure out who's going to be the one to do what that person did for Encore. So, we're getting our trials in, we're trying to get, like right now, budgets and stuff are on me, trying to build those calendars and schedule of events with money and, tied to that. So it is a struggle. But the thing is I've been a proponent of Encore, like, forever, and Anne knows, like, I've been so excited to get into Encore and use, like, I think my problem is I want to use everything, like, right now. Like, I want to use everything. And so when it's hard to, like, I need to take my own advice, like, slow down, stop, just do 1 or 2 things, get them right, get everybody using them. And then, have a planned, my husband's in IT and he tells me this too, like, I just want to open it up and, like, have everybody use everything and let's just figure it out and it'll all be great. And I know that's not realistic. So I think we're just struggling with trying to get the basics and calming Lisa down from wanting to use everything and not overstressing the coordinators and stuff like that. So, but very excited for it. It's they're great systems, and they offer a lot, not just for the department. I mean, just I can't talk highly enough about them. So it's just finding the time and the resources to really make it all happen.
Mhm.
So
I would add, I appreciate Lisa, and you think we use Encore, maybe a little bit more than you, which we might. But I will say for CTSI, I think there are parts of Encore that we don't use it well, and that financial console is one of those that I hope in the near future that we're able to use more fully, because there are so many features of Encore. So I can appreciate that, taking it a bite at a time. That's how you eat the whole elephant, because it's very overwhelming, and it's very complex. So I think the dedication to doing it piece by piece in a methodical way would help anybody that's going to use Encore. And then for E-Reg, I think it's sometimes a little bit scary to shift systems to paperless, but I think that once you do one or two in there, you see, especially for CTSI that work across so many departments, it's a challenge for us, and E-Reg has definitely helped, with those communications and signing the documents and getting across multiple departments and making it much more efficient to get, the regulatory piece done. I think it's definitely, again, taking it bit by bit.
Yeah, and I think the biggest thing about when you're looking at adopting Encore is asking, the why of what you want to get out of it. So like just echoing what Lisa said, I mean, I'm definitely an old goat when it comes to this. My prior institution was the 5th site that contracted with Encore however many years ago. So, Encore could probably be, if my staff asked me the 3 things I couldn't live without, they'd probably say Encore was something that I couldn't. I consider it my security blanket. And the older I get, the more I need that security blanket to refresh my own memory. But I will say I've had plenty of missteps with Encore, of like what Lisa said, just wanting to use everything at one time, and then it not really being something that was relatable to my department or unit and wasn't giving us information, but taking a lot of time. So, and I think we've done a good job at really breaking down like a minimum footprint of what you want to enter Encore, and knowing that Encore is that first layer of building steps to interface into E-Reg, to interface into insights, to get your metrics, to hopefully, in the future, as Epic Research is going through second phase, interface more into the Epic system. But it's going to be that launching block. And so, you want to take that time now to really look at how this can help you get, expand your goals and help your communication. We do use Encore through lots of notifications to our investigators, to our affiliate sites across the state. It's our primary metric tool. We use it for data safety, all of our deviation reporting for our data safety committees. We have a lot of data in Encore. That just helps us, that if we want to look at feasibilities or we want to look at process improvement plans, we can pull that information and kind of compare how we're doing today to the past.
The one other thing I would say is also rely on the COE and our Encore administrator, Anya. When you have questions and you might be struggling, please feel free to reach out. I think she's on this call, but I think that would, to get your answers to the questions you have. And if Anya doesn't know, Layla and Ann probably do. And if not, then Forte, or Advera, they're called Advera. They have the resources, and we can always, utilize them, to get the questions answered. Thanks, Anya.
All right, awesome. So I think we'll probably end with this last question. What are the most critical changes that we must make to face the future effectively?
That's a deep question.
Listen, I started with the easy questions, okay?
I think this past year has taught us so much, right? I mean, who would have thought that we would had to have figured out how to do research and continue to make sure patients were seen for follow-ups during the pandemic of our lifetime, right? And so for me, I think in my entire career, it's been resiliency is not an option. Like, you have to be resilient in this. I think that goes probably for anything, but in our little world, you can't get down very long. You have to pick yourself back up. You have to figure it out. You have to make it happen. And we're the ones that people go to. So there's a lot of stakes, involved. So it's really having a good network, keeping up on the ever-changing environment. I mean, education is always a good thing, seminars, all of that kind of ongoing stuff. But I think it's personal resilience to some degree is really what gets me through. I haven't been taught most of what I am responsible for. I think we all just came into these positions and we figured it out, and as we do at across all of research. And so I think it's just continuing to sign up for that every day and wake up and go, okay, I've never heard of that one before, but sure, we'll figure it out, because it has changed so much. Some of it's the same, some of it's drastically different than when we all started in research, but it's not going to be, it's always going to change. Next year is going to be different.
Yeah.
And so forth. So
I think technology, embracing the new technology, and I think to some extent we've done that this year. E-reg was something that we put on the roadmap, but we accelerated that with E-reg Lite because of the pandemic and took advantage of that. So I think technology, being able to embrace and continue to have remote capabilities. E-reg comes to mind, and also the red cap consenting process, so that we can continue to work in the environment that we did in this past year. And I think that's going to continue to be important, is to keep your eye on upcoming technology and be able to utilize that.
Yeah, I think I agree with what both Lisa and Shelley has said. I think also, we've mentioned a couple times changing the dialogue in West Virginia. And if you want to kind of look at the critical changes in our state, I think this past year with West Virginia has made some great news and some great things out there with how we've worked through the vaccine delivery across the state. And I think that's another thing that we have to critically evaluate as an institution, as what we can do well and do well, and to not always compare ourselves to every other academic institution, forcing us to think that we have to bring in programs that may not be successful for us. So learning what we should say no to, and then learning what we can do. What Extension Services has done this year has been tremendous. What community outreach groups have done. So, why can't we just tag on to that momentum and keep building that into the clinical research world, into our community, rather than focus on everything having to be siloed into the main academic membership, academic physical location. So yes, I think it's critical evaluation of resources, but critical evaluation of us and our people.
Awesome. I'd like to thank all three of our panelists for joining us today. We greatly appreciate it.